I'm going to open up for questions to the broader audience in a moment, but if I may just ask one question myself, which is that the mechanisms we've just talked about, the WHO Contingency Fund, the PEF, and the Containment Crisis Catastrophe, I've forgotten what it is, the IMF facility, are all things that are mechanisms to deploy funds relatively quickly when things go wrong. As the previous discussion raised, there's also a financing issue about the financing of resilient health mechanisms, of surveillance, and so on, to reduce the probability of these things happening. And you mentioned that that was seen within the World Bank as being. How are your organizations thinking about that second part of the task? Because the three we have talked about here are clearly the other part of it. I don't know, Priya, if you want to comment.
So that's our bread and butter, in terms of helping countries strengthen their health systems. We do that as part of our health work, both in terms of lending, but also in terms of technical assistance. IDA, as I mentioned earlier, the International Development Association, lends a lot of money to countries. Well, provides concessional funding to countries to build up health systems. I think this crisis has made us acutely aware of the need to step that up, ramp that up. Often when countries get money for health system strengthening, they don't necessarily focus that money on preparedness for crisis. So how to kind of get countries to use their health system spending to build up better surveillance systems and preparedness for crisis, and that's something that my colleagues who work on health are really focusing on. The good thing about the crisis is that it's kind of reminded us all that we need to spend more money, but there isn't a lack of money for that. I think it's more that it's not necessarily an area that's prioritized. So.
Do you want to comment on that as well?
Sure. I think, speaking of bread and butter, health systems and WHO, bread and butter. But, and I think in particular our Director General has articulated her firm commitment to resilient health systems and to strengthening health systems overall, not least as part of the universal health care model, that agenda that she's really committed to, but also I think it is the context of this. Recently, WHO convened a meeting in Cape Town, bringing together our member states as well as a number of our partners, and an enormous commitment was made there to a couple of different pieces. One is, everyone here may be aware that the international health regulations have certain core capacities. It was mentioned earlier that 30% of countries, of member states, have actually met by self-assessment the levels of capacitation that are required there. One of the things that this Cape Town meeting discussed is that we may want to prioritize even those core capacities when we look at preparedness and ability to detect and respond quickly to something like either a new virus or disease in general, or a new virus or disease in an unexpected place. And so out of that meeting has come a very large program of work, both with WHO and with our partners, that will be aligned with our broader health systems work, but that really is focusing on this prioritization of core capacities in the IHR and building those out. There's a pilot program that will go into place in the next few months in 5 countries in Africa, in accord with the outcomes of that meeting, and in also is to be scaled up into other regions as well. So I think WHO's investment and involvement in that is key to this, but I hesitate to, it needs to be had, that conversation needs to be had juxtaposed to the conversation about emergency response, but I think it's very important to remember the difference in timelines. Genuine change and genuine capacity building with country buy-in, community buy-in, with real change is a many-year process and requires government commitment, partner commitment, organizational commitment. There's many things that have to happen over many years there, where emergency response is something that needs to happen very, very quickly. And I think that our panel earlier, I think Priya a moment ago, there is this sort of, oh, the crisis is over. Let's not, we can sort of go back to normal. And I think that we can't. actually go back to normal. I think we really do need to continue to do this work of health system strengthening and resilient health systems if we are going to avoid future pandemic situations.
Thank you. And Chris, does the IMF have a role in the health system strengthening and preparedness?
No. I would say no, but what I wanted to say really was, I mean, there are many competing priorities in these fragile states. And I think it was quite nicely mentioned in the last session, attention quickly moves to the latest problem. So our focus is actually more on strengthening revenue mobilization, because not only are they poor, but the tax share of income is particularly low. And we see significant scope for raising tax revenue, which ultimately will expand the budget envelope. And secondly, on spending money efficiently and wisely through public financial management or technical assistance on public financial management. Having more tax revenue is not going to mean anything if it's not budgeted for, if the chain of expenditure doesn't work properly, so it doesn't go to where it's needed at the right time. If there's no budget reporting, we have lots of governance and transparency issues, and if the audit function is weak, we develop a sort of culture of impunity, and the wastage rates will be high.
Thank you. Okay, I'm very happy to take questions. Can I start? Janet, if you could say who you are and say who you would like to direct the question to, that would be very helpful.
Yeah. Hi, I'm Janet Vega. I'm the head of the National Health Insurance Agency in Chile, and I'm also one of the commissioners. I'd like to have, I have two questions. One, it's more a comment than a question. I think that given that this is quite circular, I don't think it will be enough with having a sort of a general strategy of how to build essential public health functions in countries. The reality in countries is that you have competing priorities, and the priority is always the most urgent issues that are related to care. So I doubt that any country will in fact build the essential public health functions unless there is a lot of pressure and a very specific work plan, as opposed to sort of a general strategy. We'll put the incentives and then countries will react. That's not going to happen. That's the comment. And then the question for Catherine. I just want to have a clarification. How much of the fund will go to human resources within WHO, as opposed to deployed and when those funds are needed? And how do you plan to basically to take that into account?
So to your question, the Contingency Fund is limited to a 3-month time period. We can only draw these funds down for 3 months. And the primary purpose of the fund is to scale up our response. So the majority of funds being spent will go to response activities, to deploying people, to making sure the equipment is in place, to making sure the logistics platform that is necessary is in place, all of those things. But some percentage of that, a minority percentage, but some percentage of that will be needed to be spent at either the country, regional, or headquarters level, with people in place to do things like process the contracts that get people onto the ground, to make sure that medevac is in place, to do all of the things that are in the machinery of an emergency response. But again, because it's limited to 3 months, it is not as though this is a fund that is going to be used to start paying and hiring WHO staff. The point of this is to scale up WHO's response on the ground. Our member states, in fact, included in the decision that prioritization of the spend of this money should be on field level activities.
Sorry, a question, the lady at back there.
Thank you everyone for the presentations. My name is Sanjana Kazi. I'm from the Secretariat of the UN High-Level Panel on the Global Response to Health Crises. I have 3 questions. The first one is to all of the panelists. If you could elaborate a little bit more on the complementarity between these funds. You've all mentioned complementarity, but how would that really work in practical terms when there is a next crisis? How do you tap into these funds? The second question is to WHO and to IMF. Who is eligible for your funds? And the third is to the World Bank. What's the timeline for the PEF? And you know, and in between, what's going to happen? Are there any ideas of, as you gear up to set up these funds, what are some of the alternatives that you've been thinking in your organizations? Thank you.
What I suggest is that, given that there are specific questions to the IMF and WHO and World Bank, is that you each answer the specific questions and give your observation on complementarity at the same time. So I don't know, Chris, do you want to start?
Okay, on eligibility, emergency lending is available to all 188 members of the IMF. Debt relief in the context of catastrophes is eligible to 37 countries that have an income that is at least 80% of the IDA operational threshold, which is currently $1,215, so about below $850 per capita, roughly speaking. Complementarity, I mean, I think the funding doesn't necessarily go to the budget. It may help to support the exchange rate, for example, so it goes going to the central bank. If it goes to the budget, it's not earmarked to any specific purpose, and I think that probably distinguishes it from the other interventions which are likely to be earmarked to particular pandemic-related expenditures.
Thank you. Catherine?
So the WHO Contingency Fund is exclusively a WHO mechanism. It is for the WHO spend on ramping up its own response. And just to contextualize that for you, the $100 million amount, as I said, was one that we calculated very clearly based on need for past emergency response. And by need, I mean what the organization needed to scale up its own response. When the UN set up its mission, emergency Ebola response mission, UNMIR, it was estimated that the cost of the response would be $2.4 billion. So the $100 million that WHO would need to scale up its response is sort of inside that envelope there. But it is not a fund that's going to be tapped into by external entities. It's really for WHO's work. Regarding complementarity, I think there's a number of places where we're thinking about how to make these complementary, but two come to mind in particular. One is that, like I said, our contingency fund isn't exclusive to outbreaks. We also will be using this in the event that a graded emergency is declared that we need to respond to as part of a conflict or as a natural disaster or any of the other kinds of things that come up. And of course, in those cases, the Pandemic Emergency Financing Facility wouldn't engage because that's not what it's for. However, in the case of an outbreak, were our contingency fund to be triggered or drawn down on, it may be worth considering how to have a mechanism so that we alert the World Bank that we're doing so and to prepare ourselves jointly in the event that we need to draw funding from the World Bank as our contingency fund, either time period or quantity of money becomes too low and really threatens the response. So I think there's those kinds of complementarities that are really useful. But then I also think that there are complementarities in terms of thinking about catastrophic events where we would be responding to, say, 5 emergencies at once. $100 million sounds like a big number. It's not. And so if you drew down a lot of that, would there be an opportunity to have additional access to the World Bank? Is there a way for us to really think about how these things can complement each other, in particular with the rapidity of access, to make the money flow more smoothly and more quickly? So can we put an agreement in place before there's a pandemic that we could trigger, so we just have a standing, could the World Bank have an account at WHO that they could just move money into? I mean, I think there's a number of different things like that that are sort of innovations that we would need to explore to see how to really improve complementarity.
Priya, timing and potential interim solutions on the PEF and your view on the complementarity point.
So I think Catherine's described the complementary point very well. I mean, I think the complementarity in terms of the way we're thinking about it, the PEF with the WHO Contingency Fund is in terms of both timing and volume. When an outbreak happens, initial funding could likely come from WHO, and then surge financing comes from the PEF, but happens very quickly because the PEF can disperse money. We're talking of within hours, days here, so not weeks and months. So. And I think in terms of the areas that the PEF would finance, there's clear complementarity. Say WHO's deployment of health workers. WHO uses its contingency fund initially for deploying X number of health workers. More money is needed. Surge financing comes from the PEF. So that's the way we're thinking about it. In terms of timeline, we are under some pressure to get this launched sooner rather than later, and we also believe that we should. Get this moving while the experience of Ebola and MERS and so on is fresh in people's minds, before the next crisis happens and minds get diverted. So we're working along a pretty ambitious timeline. As I mentioned, the technical work is ongoing right now, and you'll be hearing from our partners later today. We have here both Swiss Re, but we also have the modeling firm that's working with us on defining the trigger. Nita from AIR is here, so they'll be giving you a sense of where we are on this work. But we expect the technical analysis to be concluded by we've been saying end of the summer, and we're nearing the end of the summer, so early September, and then we'll be ready to share various design options with our funding partners and other sort of broader set of design partners. So we're planning an event kind of at the end of September where we'll be sort of presenting various options and then beginning to fundraise. Obviously, the success of this mechanism ultimately also depends on interest from donors. We are encouraged by the G7's endorsement, so we hope the G7 donors will be on board, but we want to kind of expand the donor involvement beyond G7. So anyway, to cut a long story short, our goal, which is rather ambitious, is to have this fund launched as in with firm commitments from at least a handful of donors to have this fund launched by the end of this calendar year or the beginning of next calendar year, so end of 2015, early 2016. And we're talking here of the insurance part of the fund. We can always expand it later, to bring in more players into the picture, but the insurance facility, as I described it, the target date for launching it is the end of this calendar year.
Thank you. Good morning. My name is Richard Gregory. I'm from DFID. I think one observation is it's excellent to see the multilaterals coming together in this way and talking about complementarity, and it is really important that we ensure that. And one other aspect of complementarity, we touched on the links to health system strengthening. We've touched less on the links to the wider humanitarian architecture, and that was one of the points coming out of Barbara Stocking's report, and that I'd expect to see coming out of the high-level panel as well. In that vein, I've got one question which I think would be both for WHO and for the World Bank, so both for Catherine and for Priya, around how we can best bring some of the bilaterals and the donors along in this to ensure the support that you mentioned for the mechanisms to be funded. And I think with the Contingency Fund, it would be interesting to hear a little bit about how we in WHO can work together to ensure that other donors put into it, to ensure that it is capitalised to $100 million. As I understand at the moment, it's some way off that still, and I know the UK was one of the lead donors with up to $10 million. And then on the PEF, as Priya said, the G7 endorsed that it would go ahead with the design work on the PEF, and that's fantastic to see that happening. One of the things that will determine, as we've been discussing, whether donors can come in, is showing the insurability of pandemics and then the value for money of an insurance mechanism. And I don't want to steal the thunder of colleagues doing the analytical work, but just wondered whether you have any sort of high-level observations on those questions at this stage.
Catherine, did you want to start on the donors into the contingency fund?
Sure. So one of the mechanisms that we're using to fund the contingency fund, which it has only existed now for about 6 weeks, but has been capitalized, we're nearing $20 million. So, and this during August, which at least in Europe is a pretty sleepy month. So I mean, we're quite confident we'll have a capitalization, but one of the things we're doing to help that is we're folding it into our financing dialogue. WHO has a broader mechanism for consultation and for communication and bringing our bilaterals and expanding donor base. It's our financing dialogue. The next meeting will be in November, and one of the things on the agenda there will be the Contingency Fund. So I think that's one of the mechanisms that we're doing. Certainly, we have been meeting with and reaching out to all of the missions in Geneva to talk with this, and I know that everybody has been going and visiting the donors as well. But I think we're really open to innovative ideas about how to bring in new donors, about using our donor relationships with DFID, with USAID, with OFTA, with all of these to see if we can leverage those relationships into a broader conversation. As I say, I think that one of the great dangers in any kind of public funding mechanism for anything that is a public good is the limited donor base. I mean, there's only so many donors that are contributing, and every donor has their own priorities. And really, the best thing we could do to make sure that public goods, like public health, like pandemic response, are funded is to bring more of them in. So I think we're open to innovation. I'd be happy to talk with you if you had ideas. I'd be happy to talk with anybody if anybody had ideas. I mean, I really think that at this point, the lesson maybe that we've learned from Ebola is let's have big ideas. Let's have new ideas. Let's see how we can make things work better.
Priya, the question you asked may not be susceptible to a short response, but we are running out of time. Do you want to give a succinct?
Yeah, I won't steal the thunder from my colleagues who are going to talk about this in more detail. But I think the way we need to think about value for money in this context really is in terms of the value that this PEF will generate in terms of unlocking sort of a new market for insurance, for pandemic insurance in developing countries. That's number one. And we hope that market will expand over time. Yes, insurance isn't always cheap, but again, the value that this mechanism will create shouldn't be just seen in kind of pure economic financial terms, but rather, as I mentioned before, we do expect this mechanism to really kind of bring in greater discipline and rigor in the whole kind of crisis preparedness, crisis response planning. So, that set of benefits needs to be taken into account when we're sort of weighing the costs and benefits of the PEF. But in terms of the pure financial benefits and costs, I'll leave it to my colleagues later on. It is, though, insurable. That's what we're hearing. So, there's it will work. But let's think more broadly when we assess benefits and costs.
Thank you. I'm conscious there are quite a lot of other questions in the room. However, many of the issues that we've been talking about will get picked up in other sessions, and we have run out of time and want to move on to the next panel. So can I just ask you all to thank our three panelists, Priya, Catherine, and Chris.